Who are we? We're not sellers of drugs, not mere manufacturers of medication. What we make are memories. Memories
Thank
that
you.
may
Thank
not
you,
have
DJ.
been
Thank you,
there to be
DJ.
remembered
DJ.
had a life not been lived.
Ladies
We
and
make
gentlemen,
people better, and
we are
we
redirecting
save
your
lives.
focus onto the
And
screen.
we make time too. Time we gladly give to those who have learned what so many of us have forgotten. The value of every single day. The preciousness of every breath, of every heartbeat. And we make tears, tears of thanks for the release from pain. And then there's hope, the hope parents have for the happiness of their children. You see, we don't have a strategy, we have a cause. We don't have a vision statement, we have vision. We see a future where good health is expected, not for the few, but for the many. And we don't have consumers or a target market. We have Nakato, Edwin, Okelo, and Sarah. And that is why we're not a healthcare company. We want people to live a long and healthy life. Some call it human care. We call it caring for life.
Thank you very much, ladies and gentlemen. You're most welcome to the Cipla Convention with the purpose of caring for life.
Tranquility Base here. The Eagle has landed.
This evening, we are humbled as Cipla for your presence. Thank you for having accepted to be part of this convention. Those who are virtual and those who physically made it here, we know you had a lot to do, but you said we need to sacrifice this time for this convention. We have a lot of great things planned for you. Feel free to sit wherever you are. Let me applaud those who are social distancing. We need to keep safe. COVID is real, just to remind each one of us. And tonight, we have put a lot in stock with our doctors who are going to share a lot with us. To those who are virtual, please be so keen to the screen. And in case of anything, please feel free to type in there. We'll have somebody responding to you. And after our presentations, we'll also have questions and answers that will also be handled. With us is none other than Dr. Mwebaze Raymond, who will be speaking on esomeprazole efficacy compared to other PPIs. But before he comes in, I'll have a little to say about him and more other things he will share. Who are we as Cipla? I said Cipla was founded by Dr. K. Abdul Hamid as the Chemical Industry and Pharmaceutical Laboratories in 1935 in Mumbai. And Cipla has over 34 manufacturing units in 8 locations across India and a presence in over 80 countries, reaching out and caring for life. Let's give them an applause. Thank you. And allow me invite none other than, or together with me, let's invite none other than our expert, Dr. Mwebaze Raymond. He's a consultant physician at Insambia Hospital and is the head of Department Internal Medicine with an extensive experience across internal medicine and gastroenterology. Dr. Mwebaze Raymond, you are most welcome to the Cipla Convention. We'll be hearing from you. And ladies and gentlemen, we'll also be having a session by Dr. Richard Biaruhanga, who is an ENT surgeon and with a fellowship in endoscopic science. Hand clap. Let's invite none other than Dr. Mwebaze Raymond. Sir, you're most welcome. Please feel free to walk to the podium.
Yes, good evening, everybody. It is an honor to me to be here to discuss with you this topic, gastroesophageal reflux disease and the recent advances. As you all well know, gastroesophageal reflux disease is common to most of us. Most of us experience a heartburn once in a while. And that is what we are discussing. As they have introduced me earlier on, I'm Dr. Mwebaze Raymond. I work with Nsambya Hospital as a general physician, but I have a few biases. I do a lot of diabetes and endocrinology, and I was introduced into gastroenterology because I do gastroenterology endoscopies, both colonoscopy and upper endoscopies. But of late, I think for the past 2-3 years, I think 2 years also, I've not touched a scope because of being very busy with clinical work. So I do general medicine, and I see a lot of patients with in fact, my colleagues who do scopes, once they find a clinical problem and they want to consult a gastroenterologist in courts, then they send me these patients. So our discussion will go through the definition, pathophysiology, epidemiology, clinical presentation and diagnosis, treatment, and a bit of surgical intervention, because I have a colleague now, Dr. Vasimbe, who is doing fundoplications for hiatal hernias, which are part of the etiologies of what? Of gastroesophageal reflux disease. Next slide. So the definition, I like the way they put the definition here. It is a symptom. It can be the symptom or the complication that comes as a result of the reflux disease. And reflux is stomach contents coming back into the esophagus, but they can go beyond the esophagus and reach the oral cavity, and sometimes you can inhale these contents, and they can end up in your larynx and in the lungs. So aspiration. So if these contents come unconsciously, you can aspirate them. And as we shall be seeing, some of the clinical presentations, they present with cough because of the aspiration. They can present with the dental teeth erosions because of the acid content. And of course, the esophagus is not meant to contain acid. And that sensation of acid will give you a sensation of heartburn. But interestingly, you'll find that in some people, the sensation of heartburn. In some people, that sensation is there, but it doesn't cause any damage to the mucosa of the esophagus. And in other people, it can lead to mucosal erosions, as we shall be seeing. Next slide. So, the pathophysiology, why do we reflux stomach contents? There are endogenous mechanisms to prevent this. And of course, between the junction of the stomach And the esophagus is what we call the cardia, or the lower esophageal junction. And at that junction, there's a sphincter. And that sphincter sometimes is loose and can lead to regurgitation. But as you regurgitate, you swallow a bit of saliva, and that saliva washes away. That is the spontaneous esophageal clearance. So continuously you may regurgitate, but you continuously wash away the acidic contents, and somehow you resolve the sensation of heartburn. Next slide. So the gastroesophageal reflux can result into a high intragastric pressure. And once the pressure within the stomach is high, then things will be pushed through the lower esophageal sphincter. And you find that if also the resting pressure of the lower esophageal sphincter is low, then you lead to regurgitation. And sometimes the regurgitation is transient, and that's where you get regurgitation of the contents without what? Any peristaltic movement. The relaxation. Normally, the lower esophageal sphincter should relax once there's forward movement of contents, so that it opens up into the stomach, and contents that you are swallowing should enter into the stomach. So, but sometimes it can relax without any peristaltic movements. And if you remember a bit of some of these pathologies that we see, if there are peristaltic movements pushing a bolus of food or fluid, and the lower esophageal sphincter does not relax in response of the peristaltic movements, then you get what condition? Yeah? A little teaser there. You have heard of achalasia. So achalasia is the peristaltic movements are coming in, but the lower esophageal sphincter is not relaxing. But here it is relaxing even without peristalsis. Next slide. So epidemiology, well, we just got these figures from out. Local figures here, I tried to do a bit of search, but I didn't see any local work that has been done. But all in all, this just tells us that the prevalence is real. In North America, it goes up to 27%. In Europe, 25%. In East Asia, it's about 7.8, and in the Middle East, so the problem is there. And because of the increase in obesity, as we shall be seeing, this problem of reflux has been on the increase as well. Next slide. So what are the risk factors? And as I said earlier on, obesity is one of the risk factors. Of course, dietary intake of fat, and in particular alcohol, and it's more common in Caucasians, and H. pylori is also a culprit. But certain medications as well cause your lower esophageal sphincter to relax, and leading to like calcium channel blockers and other drugs as you'll be coming across. So as I had said earlier on, the increase in obesity can lead to, I think obesity leads to probably an increase in the intra-abdominal pressure, and therefore an intragastric pressure, and therefore reflux. Next slide. So as I mentioned, yeah, the presentation that falls into the definition is the erosive esophagitis. And when you do endoscopy, unfortunately, I didn't have enough time to get some pictures of what erosive esophagitis. It is erosion of actually the lower esophageal mucosa. It gets eroded and it is bruised actually. So ORS you can find non-erosive, whereby the patient is symptomatic, but when you do the endoscopy, there's no evidence of erosion. And of course, the other presentation is a Barrett esophagus. A Barrett esophagus is transformation of the whole of the esophagus is more of, it is actually squamous epithelium. The whole of the esophagus, it is squamous epithelium. You find columnar epithelium mainly in the stomach. But because of the chronic irritation of the lower esophagus, you'll find that there's transformation of the squamous epithelium into columnar epithelium. And once that transformation occurs, then that's when we have the Barrett esophagus. And the Barrett esophagus is more of a precancerous mucosa. It is from this that it will eventually transform into adenocarcinoma of the esophagus, CA esophagus. So the lower third of the esophagus, the kind of cancers we get are more of adenocarcinoma, as opposed to squamous cell carcinoma, which is mid-third and a little bit higher. So, and that's why managing patients for GERD becomes important. It's not just a simple heartburn. Once that simple heartburn is not managed, then you are reaping esophageal cancer. Next slide. So erosive esophagitis symptoms and biopsy are visually proven the presence of what? Of GERD and non-erosive reflux disease. The pathological esophageal acid exposure will lead to, there's no evidence of what? Of erosion, as I'd said earlier on. And Barrett's esophagus, as I'd explained, is a precancerous state whereby the columnar, the squamous epithelium is transformed into columnar epithelium. Next slide. The symptoms, of course, vary from individual to individual, but overall you find that the symptoms occur either twice or once in a week, and that is mild. But if they are more frequent, then that can be categorized as severe or moderate to severe symptoms if they are more frequent in a week. Next slide. And the symptoms that earlier on introduced is the heartburn. And once in a while, any of you has experienced the heartburn. If you have not, then you are very lucky. And definitely you feel the stomach contents coming up through your throat, and sometimes you get that watery stuff flowing into your mouth. So regurgitation of the stomach contents. It's not vomiting. It is the stomach contents coming back into the what? Into the esophagus, and eventually flowing, depending on the position of the patient, they can even reach the mouth. Next. Then those are the typical symptoms. Then there are typical symptoms which we shall watch out for. I mean, if a patient presents with any of these, it could be still symptoms of reflux, and that is chest pain, abdominal pain, dysphagia for solids. By the time you get dysphagia, probably you are getting into complications. Belching and bloating, chronic cough. Some of these patients who present with asthma actually have reflux disease. And you manage the reflux disease, even the cough disappears. And the excessive throat clearing, laryngitis, hoarseness of the voice, that globus, that sensation of something stuck in your throat, episodic shortness of breath, and dental erosions, as I said, of course, sleep disturbance. So these are typical symptoms, and when a patient presents with any of these symptoms, reflux disease should be excluded, or investigate for it, and of course by doing an endoscopy and some other investigations as we shall be seeing. Next slide. So how do you get to the diagnosis? And of course, the basics still remain here, and that is history taking, physical examination, and noting the typical and atypical presentations in the history. So most patients with typical symptoms receive when a patient is with typical symptoms, you try this patient on a PPI, and if he responds to the PPI, you don't have to undergo a diagnostic investigation. The PPI, response to the PPI is a diagnosis, actually. You can end it up there and say, well, if you have responded to my PPI and your heartburn has cleared, then probably, not probably, then definitely the fact that you have responded, then you must have been having a GAD. Then for those people who don't respond or have those are typical symptoms, then you can go ahead and do an endoscopy. And an endoscopy is the initial choice of an investigation. And it will sort out whether there's a cause of dysphagia, a cause of painful swallowing, that is odynophagia, and a cause which could have led to weight loss. And in case a patient has upper GIT bleeding, an endoscopy will definitely tell you what is the lesion that is explaining the symptoms of the patient. Next. So here we look at, I think you have to continue. Next. Go back. Well, here, it has not come out well, but at the end of the day, the long-term complications, of course, apart from the poor quality of life these patients experience, the esophageal damage that were talked about, apart from getting cancer of the esophagus, you can get strictures and a Barrett's esophagus, and of course adenocarcinoma, as I mentioned earlier on. So it is paramount that the GAD should be managed. Next. Then another investigation that can be done. Well, these are the investigations, and the 24-hour ambulatory pH monitoring. That is, of course, pH is either low or high. Low pH is acid, and high pH is alkaline. And of course, we're dealing with acid and low pH. And can we prove that the pH in the lower esophagus is actually low? And that's when you do a 24-hour ambulatory pH monitoring. There are probes that can be put down the esophagus, and the readings of the pH can be monitored. The pressures in the lower esophagus can also be assessed, and to see whether the pressure at the lower esophagus is low or high, leading to the reflux, and that is esophageal manometry. And of course, we talked about the endoscopy, and then barium meal or barium swallow. It is still a useful investigation, especially when there are obstructive lesions. In cases of achalasia, then the barium contrast will mark out the lesion very well. Next slide. So to demonstrate or quantify that there's presence of a low pH, the gold standard is a 24-hour pH monitoring. I only saw this investigation being done in Italy, in Milan, when I was undergoing some training. That's the only place I've seen it being done. And the patient has to correct the symptoms of heartburn. Whenever he feels heartburn, he notes the time, and when they are reviewing the readings, they can correct the symptoms and the level of the pH at that time. So yeah, this is good to know, but I think we're still far off. Maybe Cipla might assist us and get some of this equipment here, and we begin investigating our patients well. Next. Of course, this is all about the pH monitoring and how you interpret the results. Next. So even the manometry is assessing the pressures, and of course it's the gold standard for achalasia, whereby the pressures at the lower esophagus are very high, and it does not relax in response to peristaltic movements. Next. Still here it is about the endoscopy, and for patients who are candidates for laparoscopic surgery, fundoplication, then you'll have to confirm with an endoscopy. And then the endoscopy will tell you whether there are ulcers, whether there's a stricture, a Barrett's esophagus. You are able to do a biopsy, and also grading the grading of the esophageal erosions are graded based on the Los Angeles classification. And that is for the endoscopist. You might get these reports. Next slide. You might get these reports, and next slide. And you find that the endoscopist is reporting based on the next slide. Yeah, that is the grade Los Angeles classification of esophageal erosions. There's grade A, grade B, grade C, and it depends on the columns and the extent of involvement of the lower esophagus with the mucosal erosions. Next. So as I'd said, barium swallow is useful in when there are lesions or when there's an obstruction, when there's a tumor, then it will be very clear. And so it is still a useful investigation, but with the coming in of endoscopy can tell you at which spot the lesion is. We can measure. You can be able to take a biopsy. You have the pictures. And here you have to leave it to a bit of imagination. Next slide. So how do you manage GAD? And number one is lifestyle modification, then medical, surgical, and endoruminal therapies. These are not yet here, but we shall make just a mention on them. But what we shall mainly emphasize is the lifestyle modification and the medical management using our PPIs. Next. So lifestyle modification is the first line treatment, and propping up the patient in bed is very important. You encourage the patient to use more pillows, and avoid late meals, and avoid a lot of fluid in the late meals. Eat early, sit, and maybe for an hour or two before going to bed. And for those who are obese, aim at a BMI of less than 25, and avoid the carbonated drinks, alcohol, and even beverages, caffeine, tea, and of course smoking. Next. So those are the things in lifestyle. Then for the medical management, antacids, and that's why you have your magnesium trisilicate, and then proton pump inhibitors, and H2 receptor antagonists, and prokinetics, as we shall be seeing. Next. These slides are not coming out well, but here we are talking about the prokinetics, and the metoclopramide, that is Prasil, and the domperidone are the prokinetics that we use. Next slide. Proton pump inhibitors are considered the most effective in the medical management of GAD, and they offer profound and consistent acid suppression with typical symptoms. With typical symptoms, an 8-week course of a PPI is recommended. And this is something that we have to practice. You find that most times we give these PPIs for a short time, but at least give PPIs for a minimum of 4 weeks to 8 weeks. You can give a trial of 2 weeks, but if there's a good response, then prolong your treatment so that you get better outcome. And PPIs have demonstrated different levels of satisfaction ranging from 56 to 100% as compared to with other anti-reflux medications. So the response rates, you can go up to 100%, but on average, about 80 to 90% of the patients have satisfaction with use of PPIs. Next slide. So currently, the available PPIs, you'll find a lot of PPIs on the market. And from here, by the time you leave, you'll realize that not all PPIs are the same. And but all of them try to achieve one goal, that is acid secretion suppression. Next slide. So proton pump inhibitors inhibit gastric acid pump, that is that potassium ATPase pump, and it is a prodrug. It has to be activated in the presence of acid so that it blocks the proton pump. And that's more the reason why a PPI should be taken in the morning, so that whenever you are eating, once you stimulate acid secretion, then the pump is already blocked. Don't take they work for 24 hours, but you begin eating in the morning, so that across the day, acid suppression is achieved. Next slide. So PPIs diffuse in the parietal cells in the stomach and accumulate and are activated by proton catalyzed formation of sulfuric acid. This prevents the drug from diffusing out. The activated form is irreversibly binds to the sulfuridyl groups, the cysteines of the. So this is how this biochemistry of this drug, that's how it works. But at the end of the day is to block acid secretion from the parietal cells. Next. So large studies have compared PPIs with H2 receptor antagonists. We no longer use a lot of these H2 receptor antagonists, but cimetidine is a H2 receptor antagonist. Famotidine is a H2 receptor antagonist. Actually, famotidine is being mentioned as a drug that has some benefits in COVID management. But on our market and over time, these H2 receptor antagonists have fallen out of favor, and rarely do you find us be using them. So, and definitely studies have shown that PPIs have an upper hand over the use of H2 receptor antagonists in management of GAD and NAD as well. And though recently the safety of PPIs has raised questions, and actually some studies on ICU patients empirically are given PPIs, and it has been found that in some cases it leads to getting certain particular infections. And of course, the nutritional deficiencies associated with long-term use of PPIs is the B12 deficiency, because you need acid to help you absorb your vitamin B12. So you might get, intermittent use, that's why you have to, we talk of 2 weeks or 8 weeks. These are some of the complications you have to watch out for. Or you have to have, but some patients might, in fact, I've met some patients who chronically take a PPI, self-prescription. So you watch out for such patients. They can end up with these kind of complications. Next slides. So PPIs, as we had said earlier on, can provide 57 to 80% relief from erosive esophagitis, and up to 50% of patients with NAD. The number of patients who respond to PPIs in NAD is less. And probably some of these patients with non-erosive reflux disease could be hypochondriacs who probably maringaras. That's why they continue complaining despite giving them adequate PPIs. So there is healing of the erosive esophagitis and can be obtained at percentages greater than 85. And so the standard treatment for GAD remains use of PPIs. Next slide. Here, a little bit about the dosaging, and for for GAD, if you want to heal erosive esophagitis, you can give a dose of between 20 to 40 milligrams for 4 to 8 weeks. And you can do a maintenance for 20 milligrams once a day. And if a patient has symptomatic GAD, then you can give it 20 milligrams once a day for 4 weeks. And if a patient has dyspeptic symptoms, but you still want to use a PPI, you still want to use an NSAID, you can combine the NSAID with what? With your PPI at a dose of between 20 to 40, and you can even stretch it up to 6 months. Yeah, you find such situations. You really want your NSAID, but at the same time, you want to protect this patient from NSAID-associated gastritis or GAD. So you combine the PPI with the NSAID. Then treatment of peptic ulcers in the triple therapy, esomeprazole has a big role there in combination with the other drugs. I've never made a diagnosis of Zollinger-Ellison syndrome, but that is a gastrinoma whereby you have excess acid secretion, and in these patients, actually, the dose is much higher, 40 milligrams of a PPI, esomeprazole, twice a day. Next slide. Efficacy of esomeprazole compared to other PPIs. Here they compared the esomeprazole with labeprazole, omeprazole, lansoprazole, and they were looking at clinically proven healing of the reflux esophagitis compared to omeprazole and lansoprazole. So it came out clearly that esomeprazole performed better in terms of the duration in which the acid suppression occurs at a pH of less than 4. And the esomeprazole offers up to 14 hours compared to pantoprazole giving us 10 hours, and the labeprazole comes in next. And so omeprazole, the duration of acid suppression performed better. Next. Here they were comparing a placebo against, of course, against the esomeprazole, moderate to severe heartburn at night. Well, you want to see whether is it the effect of esomeprazole that your heartburn improves, and definitely the number of patients who improved on esomeprazole was higher than placebo. Next slide. Here was a satisfaction survey looking at how patients experience when you switch them from any other drug to omeprazole at consultation. You find the patient comes, either he has been on something or not, then you switch them to esomeprazole. And how do they respond? What happens to their symptoms? And definitely their symptoms improved. If you had a heartburn at 46%, you find the heartburn rates are reduced to 0.9. If you had the rectosternal pain, if you had regurgitation, all across the board, nausea, vomiting, all these improved across the board compared to what the patient was on before switch and after switch. Next slide. Esomeprazole offers better acid control as compared to omeprazole. Well, omeprazole is one of the first PPIs that was developed, and of course, esomeprazole has a bit of superiority over omeprazole, and it offers at least between 16 to 24 hours of acid suppression and better response to the symptoms. Next slide. So, which candidates should we refer for surgical intervention? And either patients have side effects to the medical management, either they are not compliant to medical management, or wish to discontinue the long-term use of medical management, or they have a large hiatus hernia and it needs to be corrected. There's a lot of regurgitation, or they are not interested in medical management, and the pH levels remain high despite maximum doses of your PPIs. So such patients should be offered benefit of surgical intervention. And next slide. And here, that's when they do the laparoscopic anti-reflux surgery. That's what I was talking about. My colleague, Dr. Wasimbe, I think is doing some of these procedures. Then you can do gastric bypass surgery. This Linux reflux management system, then electrical stimulation. These are a little bit technical. I just put them there, just stimulate your mind. Next slide. So at the end of the day, those are the interventions that can be done. But for our purposes and for the purpose of this meeting is to diagnose the patient better, identify patients with typical symptoms, don't ignore atypical symptoms as mentioned, and offer a patient a PPI at the right doses for the right duration of time, and also, of course, do relevant investigations to confirm your diagnosis. And I would recommend that patients who have had the symptomatic symptoms of heartburn and for a bit of time, and they are not necessarily above the age of 40 probably, an endoscopy should be done so that early manifestations of mucosal damage or Barrett's esophagus can be picked up early. We haven't improved our interventions. A Barrett's esophagus can actually be excised. There's what they call a musectomy, whereby the mucosa, the precancerous mucosa can be excised off. And that means the landmarks of that Barrett's esophagus have to be identified, and the mucosa can be excised off. And that can be curative. You catch the cancer before it is overtly adenocarcinoma. And that's why the role of endoscopy and those kind of interventions have to be done. So that said, I want to thank you for the time you have given me and the attention you have given me. Thank you very much.
Okay, let's give a big hand clap to Dr. Mwebaze. Dr. Ray, thank you very much. At one moment, you spoke about the BMI, and I saw all doctors focusing on me. Ladies and gentlemen, I'm working on my BMI. Do not get worried wherever you are. The next time we are here bringing in new things for you, you will see me with that weight that you will also say, wow. Allow me to recognize none other than the Chief Executive Officer of Cipla Quality Chemical, and that is Mr. Nevin Bradford. Wherever you are, just wait for them so that many of them can get to know you. I told you we have a lot in stock, not forgetting that whatever packs are on that table belong to you. You're not just going to listen, but you're going to carry some back home. Together with me, let's invite Dr. Richard Byaruhanga. I told you more about him, but then he has more and more. I only request that he will just go within the time that is stipulated for him. Thank you very much. Once again, a big hand clap for Dr. Mwebaze and Dr. Richard. Thank you. You're most welcome, sir. Hello. Let's use this microphone. COVID is real. Wherever you are, those who are social distancing, I'm excited.
Good evening, colleagues. Good evening, ladies and gentlemen. if you've ever been challenged to speak after your teacher, you will feel for me this evening. Dr. Raymond is one of those that taught us in medical school. Don't look at my gray head and then begin to calculate his age. But it's a challenge to speak after your teacher, but I'll try and do my best. He has made life very easy for me because he has gone through some of the things that I prepared to talk about, and especially in relation to treatment of God and drug treatment specifically. So let's go to, I'm sorry I forgot to introduce myself, but our MC ably did. I'm Ricky Vyarahanga. I'm an ENT surgeon in private practice. I'm an endoscopic sinus surgeon, and I work with IHK and St. Catherine, but also teach as a senior lecturer with UCU School of Medicine. Slide number 7, please. Most of some of the things that I had, we've gone through with Dr. Raymond. So let's just go on to slide number 7, please. PPI, the one before, after that one, next. Yes, thank you. Now, there are several ways of treating God. And for the purposes of our meeting this evening, we are zeroing in on PPIs, the proton pump inhibitors. And we'll even go down further to being a little more specific and talking about esomeprazole. But for you and I who are clinicians, thinking about how we are going to effectively manage or treat our patients' conditions, what are the things that we think about when we are treating our patients? Number one, if it's drug treatment, you're thinking about the cost. Number two is the patient satisfaction. How have their symptoms been cleared? And number three is availability of the drugs that you're going to prescribe. And so when we think about PPIs, next slide, I want to talk about specifically esomeprazole. Esomeprazole is an isomer. It's an S isomer of omeprazole. And therefore, because it's an isomer of omeprazole, it has increased bioavailability and better acid suppression. Next. So, but when you think about that, you'll say, but what about the costs? And when you think about the costs of these drugs, the PPIs, in treating your patients with GAD or any other reasons for which you have to prescribe this, the question will be, if I'm prescribing omeprazole 20 milligrams and esomeprazole 40 milligrams, what's the difference? I looked up some studies and I just quoted 2 of them. But these 2 studies have compared a dose of omeprazole and 20 milligrams of omeprazole and esomeprazole 40 milligrams. And they found that esomeprazole provided greater acid control in patients with GAD and keeps the stomach pH at higher than 4 for a longer period of time. If you have less acidity, you know that the patient will have less pain. You know that the patient will be more comfortable. But then someone will say, why not increase the dose of omeprazole? Because it seems to be a cheaper drug. Another study I found, next slide, another study I found compared 40 milligrams of esomeprazole with 40 milligrams of omeprazole. Remember, the usual dose, adult dose for omeprazole is 20 milligrams. But you're thinking, what about increasing the dose of omeprazole? This study found that esomeprazole at 40 milligrams still provides more effective acid control than omeprazole at 40 milligrams. And of course, we are talking about twice the standard dose of omeprazole. So still, esomeprazole still has a better effect. The patient will have a better outcome. Even better, friends, when we talk about esomeprazole, Cipla has come up with technology that brings a brand that is even better than the regular esomeprazole. And how is this? This is by introducing a drug with a new technology called the MAP technology. The MAP technology, next slide, basically is multiple unit pellet technology. We have seen this on the market with a drug called Nexium. You've heard of that drug, you know it? But we know that Nexium is quite expensive in our market, isn't it? Not many patients can afford it. Cipla has now come up with a compound which is a generic of esomeprazole, and it is the first generic with MAP technology. The Esomax that we're talking about this evening. But what advantages does the MAP technology have compared to the regular esomeprazole? MAP technology basically is prepared by compaction of modified release coated pellets filled into capsules or tablets. And it has distinct advantages such as enhancement of drug dissolution. In other words, the drug dissolves faster. There is ease of coating with the desirable sustained and controlled release. And it combines, so this MAP technology combines the features of both controlled release tablets and modified release capsules in one dosage. And that's a great advantage. It therefore means that compared to the regular esomeprazole, when you have esomeprazole with the MAP technology, with the multiple units, you have better availability of this drug to the patient. Therefore, the symptoms will easily be dealt with. If you are like me, I'm usually curious. So I tried out and I thought, let me see what this drug looks like. So on the table there, I got the esomeprazole, the Esomac, and I broke one tablet. And when you look in, there are some of the capsules that we have on the market which have the pellets, and the pellets you can easily see them. If you don't have a good eye, you barely see these pellets. But if you scratch on the tablet, you will see the pellets falling apart. That's the MAP technology. It makes this drug more bioavailable to the patient when they swallow it. And finally, my last slide. Next, please. So these smaller, the pellets are much smaller. The ones in this tablet, in the Esomac, are much smaller than the usual pellets that we see in the capsules. And therefore, it gives modified release, hence better bioavailability, like I mentioned earlier. There's uniform drug release, greater availability of the drug, faster action, and uniform drug absorption in the stomach. Because of that, also, of the MAP technology, there is uniform emptying. Go backwards, please. Down, the last slide. Yes, before that. Yeah, thank you. So there is uniform emptying of the micropellets from the stomach into the small intestines, which facilitates rapid dissolution and the drug release, resulting in early Tmax and Cmax. That means the peak time and the peak plasma concentration are much faster. And there is also lesser possibility of localized irritation in the esophagus because this drug easily slides through the esophagus and gets into the stomach where it is needed. Ladies and gentlemen, thank you for listening to me.
Wow, I just realized it's a very good timekeeper. Ladies and gentlemen, let me redirect your attention to the screen for that video. Let's give him a hand clap again. It is not easy to present and be as brief as that.
Recording in progress.
Thank you, DJ. Thank you very much. To those who are virtual, our technical team is still working on you. Ladies and gentlemen, for those who have questions and answers, questions upon our presentations, please, we'll have a question and answer session that your area of need shall be reached out. Together with me, allow me invite none other than Dr. Pade, who is also the country manager. Is that doctor? Or Mr. Pade, right. The country manager, Cipla QCIL. Thank you. You are most welcome. He will be presenting on a product session on ESOMAC, and that is MOPS. You're welcome, sir.
Ladies and gentlemen, good evening. My name is Pade Mukwaya. I'm the country manager, private market business of Cipla in QCIL. I'm not a doctor. Yeah. Having introduced myself, I have the pleasure to humbly introduce some of my members whom I work with, especially the team in the gastro division. These guys who constantly come to you to try to deliver the Cipla promise of caring for life, to extend that to the patients, which is the purpose of why we exist as Cipla. So Yazid Ndote, a shout out to you. Ruth Kabuji seated right here. Ivan Kojo behind there. Musimenta Ivas and Kayemba Nelson. These 5 dynamic guys try to do everything every day to ensure that the patients have the best products available to you to extend to them, and I give this moment to them to thank them so much for the work they have done. So in the interest of time, I would have said go to the last slide, because Dr. Richard and Dr. Raymond, they have done a wonderful job to inform us that esomeprazole is the PPI of all PPIs. So any azole, like Dr. Ricky says, you put esomeprazole as the father. But today, what we have come is to deliver a superior promise that there is still something we can do in the PPI space to give the patients better care. And that is the technology we want to emphasize today. In my part, I'll emphasize the MAPS technology. Dr. Richard has done a tremendous job. But I want to say why it is a big deal away from the conversation. I just want to draw your attention to this intriguing picture of the cosmos, an astrological picture. We see hundreds of stars. But if you study this deeply, it is even more intriguing. You are able to see the moon. And not when this man took the step to the moon, it was a small step. But for us as humans, it was an advancement to the human race that we are able to accomplish a lot with science. So if we embrace science, even in medical care, we can achieve superior results. And what we want to say today is that in the management of PUD, in the management of GAD, in the management of NSAID-induced peptic ulcer diseases, you use a superior technology of esomeprazole. And today we are introducing, next slide, ESOMAC MAPS. ESOMAC MAPS is esomeprazole delivered in a far superior technology called the multi-unit pallet system, which Dr. Ricky has alluded to. So we have esomeprazole, next slide. We have esomeprazole available for the treatment of GAD, next slide. This doctor has alluded to it. In peptic ulcer disease, all these symptoms, if you see all this symptomology for your patients, blood in the stool, nausea, heartburn, intolerance to fatty foods, chest and abdominal pain, feeling of fullness, where patients come to you and you feel they could be having peptic ulcer disease, MAPS technology is where to go. Next slide. This slide has been presented. We have to improve the quality of life for our patients. We have to prevent Barrett's esophagus, which is a precursor for esophageal cancer. The last time we checked with the Uganda Cancer Institute, esophageal cancer was the fourth leading cause of cancer, the fourth leading cancer in Uganda. So it is a big deal that we ensure that we protect the esophagus of our patients. Next slide. So we are delivering MAPS, multi-unit parallel technology, with ESOMAC in two strengths. One is ESOMAC MAPS 20 milligrams and ESOMAC MAPS 40 milligrams. We ensured that you have samples available on your table. And Dr. Rich has said, even if you take a tablet and you scratch it, you will see the army of pellets. They are ready to go and evenly be distributed in the esophagus and the gut of your patient. And there will be uniform absorption of this drug, better symptom control, and all the advantages which doctor has said of esomeprazole, especially the MAPS technology, other than the ordinary PPIs. Next slide. Okay, just to take you through some of the studies which we came across with. Symptom control is extremely important when you are managing patients with GERD and PUD. 90% superior efficacy in terms of symptom control. You get that with ESOMAC MAPS. So here there is a study which shows that within 4 weeks, to patients who come to you with heartburn, patients who come with acid regurgitation, patients who come to you with upper abdominal bleeding, there is a significant, more than 85% reduction in this symptomology. So when you compare with other PPIs, just to roughly running through, that we have 58.6% superior outcomes compared to pantoprazole, which is 36.9%. And when you compare esomeprazole with rabeprazole, rabeprazole is far lower at 48%. Next slide. This one, doctor has also presented this slide. Doctors, symptom control is extremely important because symptoms is what brings these patients to your chamber. And with ESOMAC, you'll have a very strong, fair confidence that you will be in a position to manage the symptoms of your patients and give them better outcome. They will adhere to your medication because they are getting results, and quick, consistent results. Next slide. So all the patients who came with symptoms, this one doctor has said, you can see in the blue, patients who came and at consultation, they had all these symptoms in black, up. But those who were managed with esomeprazole, ESOMAC MAPS technology, you can see how the symptoms rapidly almost disappeared. Let's go. Okay. Superior mucosal healing is extremely also important. With esomeprazole, you have 93.7% mucosal healing. And if you use omeprazole, it is only 84.2%. If you use pantoprazole, it is even much lower. It is 75%. But if you deliver the MAPS technology to your patients through ESOMAC, you will have 81% healing rates for your patients. So broadly, the healing rates using MAPS technology of esomeprazole is 92%. Wonderful percentage. Next slide. Next slide. Okay, this one, doctor said also, consistent suppression of acid for 16 hours. Look at what the other azoles are doing, and you can know that ESOMAC is much, much better in suppressing acid for a longer time. Next slide. Okay, the superiority of once daily dosaging is also evident in ESOMAC. The tablet in front of you, if you give it to your patient once a day, consistently, like doctor said, for 4 to 8 weeks, you'll have tremendous results, 90% like we have been saying. Next slide. Okay, Doctor, I want to take this opportunity to invite you, ladies and gentlemen, to take a leap for your patients with the MAPS technology. This is a slide which Doctor has presented, a greater confidence in clinical outcomes with the proven absorption and greater bioavailability using the MAPS technology. Next slide. Increased safety profile and better patient compliance. Next slide. Thank you very much.
Thank you very much, Mr. Paddy. Let's give him an applause again. He's been, I'm going to ask for one thing, one request. Let's all stand on our legs. Let's all stand on our legs. I know what it means sitting for an hour and you're getting a lecture. And I'm speaking to doctors. I'm not a doctor, but I'm proud of you guys because you are our ambassadors out there to the general public. Each time you recommend such a superior, exceptional technology that has been launched today, you're also lifting Cipla and you're showing that there is love for Cipla. Let's put our hands together and clap for the team that came up with that exceptional superior technology of ESOMAP MAPS. Yeah, that's not enough. Let's give it an applause. It's not easy. It's not easy. Thank you very, very much. I'll again say thank you for having honored our invitation. Let's get back to our seats because we still have more in stock for you. DJ, let's have that video again on PyroKit. Ladies and gentlemen, we still have, thank you.
One of our gastrointestinal treatments is PyroKit. PyroKit is undoubtedly the knockout punch for H. pylori. Let us look at 5 reasons why PyroKit should be your brand of choice for H. pylori management. Round 1. Clinically proven in H. pylori eradication. PyroKit with 250 milligrams of clarithromycin achieved an eradication rate of 87.1% and cure rates of 84 to 93%. Round 2. Favorable side effects profile that supports treatment completion. PyroKit's reduced side effects profile enhances patient compliance. Round 3. Guideline supported. Clarithromycin kits remain preferred as per the latest ACG guidelines in treatment of naive patients. Round 4. 500,000 plus patients in Uganda have been successfully treated. More than 500,000 patients in Uganda have been successfully treated with the PyroKit. Final round, round 5. PyroKit is a product with quality you can trust. Cipla's 85-year heritage, 1,300 scientists, and 6 R&D facilities ensure the highest quality standards across its 46 manufacturing sites. PyroKit, the knockout punch for H. pylori.
Jerusalema ikayalami ilondoloze.
Wow, and that is our boxer. Wow, come on.
Jerusalem
Taking punches
ikayalami
on H. pylori.
ilondoloze.
There we are. punches released on H. pylori by Pyrokid. Rates 87% on H. pylori eradicated. Wow. With 500,000 plus patients in Uganda successfully treated. This is not Golora. Golora punches on top, but Pyrokid punches H. pylori inside and pulls it out. So for 500,000 plus people have been successful. Let's go. Watch that. Watch the punches. Watch the punches. Thank you. Thank you, thank you, thank you, DJ. Thank you, DJ. Wow. Hey, ladies, first wait, don't just go away. I was reminding our doctors that this is not Golola. This is Pyrokid. Golola kicks you on top, hits the top of the body. But these are punches going into the bone marrows. These are punches going into the blood. These are punches reaching everywhere in the body and pulling out what we call H. pylori. And today, rates at 87% are eradicated of H. pylori, and we have over 500,000 plus patients in Uganda successfully being treated. What will you do when you get back? You are our ambassadors, I told you. Give yourselves an applaud. Give yourselves a hand clap. For we know you are going to send the same communication. Thank you very much, ladies. Thank you very much. At this time, allow me to invite Mrs. Ruth Kabugi for the Pyrokid product session. Wherever you are, Ruth, are you with us here? Oh, thank you very much. You're most welcome. Give her a hand clap. She's fast, you know, she's a quick lady. You see how active she is. You're welcome. COVID is real. I won't forget reminding people.
Thank you. Good evening, ladies and gentlemen. How are you doing? Yes, my name is Ruth Kabugi. I'm a medical representative. I work with Cipla Pharmaceutical. And today I'm going to talk about the most prescribed, the most trusted, and the kit that has stood the test of time. Pylokit. Next. The punch with the 5 power. I'm going to share with you 5 reasons why Pylokit should be your brand of choice for H. pylori eradication. Reason number 1, why Pylokit should be a brand of choice. It's clinically proven in H. pylori eradication. And I'm going to share why. In a systemic meta-analysis of 19 studies, that's quite a number, right? Yes, with a sample size of 4,134 patients, showed that the 250 clarithromycin achieved an eradication rate of 87.1% compared to the one of 500, which is 88.4. It's quite significant. Also, in the case of dual resistance, you can still achieve a cure rate of 84 to 93% in both cases when clarithromycin and nitronidazole at high and low minimum inhibitory concentration, respectively. Reason number 2, why Pylokit should be a brand of choice is that it has favorable side effects profile that support treatment completion. Even before I go beyond this room, I believe at one point we've had to take treatment, antibiotics for 5 days. And on the 3rd day, you're already contemplating. Huh? You can imagine if the side effect is there. And I believe you've had your patient, the first day or the second day, they come back and they complain about the side effect. And in fact, some of the patients, they will tend to go back to PPIs. Yes? And yet we need to eradicate the H. pylori. So, and as you know that in clarithromycin is a bacteriostatic and it's time dependent. So compliance is really very important. And it's important to give a kit that has a very good profile, side effect profile, a favorable side effect profile. In the same study I discussed earlier, a meta-analysis of more than 4,000 patients showed that when you increase the clarithromycin from 250 to 500, you increase the side effect by 50%. And even the compliance is less than 60%, which reduces or decreases the eradication rate by almost 30%. Pilokit reduces side effect profile and enhances patient compliance. Reason number 3, why Pilokit should be your brand of choice is Pilokit quality you can trust. Cipla's 85 years of heritage. This was started around World War II. I don't think some of us were born. Yes. So we have over 1,300 scientists dedicated and 6 research and development facilities to ensure that we have the highest quality standard across its 46 manufacturing sites. And you know that we have a plant here in Ruzira. Some of the doctors have actually visited our plant in Ruzira, and they were really amazed on the standards we offer. And it's also very important for any generic company to present pharmaceutical equivalence to the innovator. And Cipla, our products are bioequivalent to the innovator, which is an important pointer to the clinical efficacy. As doctor was discussing, and Paddy also shared with you about ESOMAC being bioequivalent to the innovator. That speaks a lot about the quality, and Cipla, we are here for you to give you the quality you can trust. Point number 4, why Pilokit should be your brand of choice. It's guideline supported. As you know, with the recent latest ACG guidelines, clarithromycin kits remain preferred in treatment of naive patients. Reason number 5, why Pilokit should be your brand of choice. Numbers don't lie, right? Numbers don't lie. If I have 100 bob in my pocket, it's 100. It cannot be 10,000, right? Yes. So Cipla is the only company that can claim this number. We have more than 500,000 patients in Uganda that have been successfully treated using Pilokit effectively with a composition of lansoprazole, 30 milligram, clarithromycin, 250 milligram, and tinidazole, 5 milligram. So we are celebrating 500,000 H. pylori success story with Pilokit. So beyond this, there's a lot we can do to ensure that our patients really get the H. pylori eradication is successful. The next slide. It is, as the current guidelines recommend, that H. pylori treatment should be given 10 to 14 days. As I discussed earlier, Clarithromycin is a time dependent because it's a bacteriostatic. Therefore, the duration of action is very, very important. So it is really important to talk to to the patient about antibiotic, how to take antibiotic correctly, and antibiotic resistance, and the danger of the misuse, because compliance is the key. Point number 2. It's advised that to only prescribe antibiotics when needed. According to the latest guidelines, this dosage should be as per patient history. It's very important to ask, to consider, is the patient antibiotic naive? Do we really need to go to the higher strength? Has the patient been treated for H. pylori in the recent past? Do you really need to use a high-strength antibiotic at this stage? So these are things we need to consider as we are dispensing or prescribing the antibiotics. Point number 3, it's really important to report antibiotic resistance, infection to surveillance team, and tests of cure is recommended to follow up after 4 weeks. This is after completion to establish treatment failure. So let's reassure our wins with retesting. So we need to encourage our patient after completion of treatment to come after 4 weeks, and we do the test to confirm if H. pylori was clearly eradicated. Point number 4. So as you know that we still eat Rolex from that Rolex guy, even if we treat our H. pylori and still eat the food which has not been hygienically prepared, we are still going to have the risk of having infection, and sometimes is perceived as resistance. Even in our household, we treat H. pylori, but we have that house help who is still preparing our meals. So it's really important to emphasize on the, hand washing, hygienic food preparation. And when you advise this patient, we'll be able to win, to fight against H. pylori infection. Point number 5. So with the prevalence at a whopping 80% in Africa, more disease and awareness, more testing, right management, and therefore subsequent cure can strengthen the fight. The next slide. Let's fight Africa against H. pylori. Cipla is celebrating 500,000 H. pylori success using PyloKit. So let's pass the benefit of PyloKit to our patient, considering the 5 points that we've discussed. Thank you very much.
Those hand claps were not enough for the one and only Ruth Kabuji. Ladies and gentlemen, we are having our Cipla Ninja launch. DJ, give us a sound as we continue with our Cipla Ninja launch. I told you we have a lot in stock for you. And at the end of the day, please do not leave us without having a meal. Thank you. And that is the Ninja. Wow. Wow. Don't draw near her. Ninja warrior. Cipla Ninja warrior. Wow. Yes, And that is the Cipla Ninja Warrior, displaying the tactics of fighting out everything in the body. Yes, releasing all that pain. Aha! Whoa! Thank you, DJ. A big hand clap for our lady. I thought she was going to come and find the doctors and the doctors would run out. Thank you, madam, for not drawing near them, because we're going to remain with an empty hall. They do not know what you're holding. Ladies and gentlemen, we are running short of time, but we're trying very much to go within our limits. Allow me to invite Madam Josephine Adera, Mrs. Josephine Adera, who will be presenting on the Cipla Dawn, who will be having a presentation on the Cipla Dawn, and hope the video has been prepared as well. You're most welcome, Madam. COVID is real.
COVID is real. Good evening, ladies and gentlemen. Guys are tired. I promise I'll be precise, to the point, so that we move to the next session. Slide 1, please. My name is Josephine Adera, the Trade Marketing Manager for Sub-Saharan region at Cipla. Thank you very much. Thank you, Dr. Raymond, for taking us through a very inspiring and educative presentation on esomeprazole efficacy compared to other PPIs. Thank you, Dr. Richard, on taking us through the innovative delivery system in GAD management. And thank you, Ruth and Paddy, for the product presentation. Now to the amazing, newly launched, the best and newbie in the market, Cipla Dawn paracetamol tablets. When do you, as a doctor, prescribe a dispersible paracetamol? I want us to think about this question as I'm rushing through the presentation. When do you, as a doctor, as a healthcare professional,